Hope you've been enjoying our Room Now live coverage of the ACR 2023 that is in San Diego. And here today, whom I have is Sheila Reyes and Eric Dein. We are going to be talking about lupus, all the things that we've seen about lupus. This is our lupus panel and our lupus discussion. So Sheila and Eric, will you introduce yourself? Go ahead, Sheila.
Hi, good morning here from the Philippines. Again, I'm Sheila Reyes reporting virtually. It's been a hectic week so far, but lots of learning and challenging cases that we've seen, especially for lupus.
Absolutely. Eric.
Greetings from, I'm in Jersey City, New Jersey, and it's been a great conference. It's just been winding down, and so just the overload of information, it's like learning from the fire hose.
It is definitely like the proverbial open your mouth and we're shoving it down. So what did you learn and what do you want to share with our audience?
Sure. I can start with, one of the plenary sessions from Tuesday, which is abstract number 2427. For lupus, there's been certainly a lot of information from Johns Hopkins, Dr. Andrea Fava and Dr. Petrie, and this plenary session from Dr. Alessandra Ida Celia. They've been looking at quite a lot about various urinary biomarkers and different markers of lupus nephritis. And in particular, they looked at PR3 antibodies in lupus nephritis. And they had some very interesting findings that they presented showing that there's more proliferative, the PR3 is more common in proliferative than in membranous disease. It's mostly located in the tubulointerstitium. And when they do biopsies, they find that the PR3 cells are higher in the glomeruli at a higher density with lupus nephritis. And in particular, what's interesting about their findings is that it really correlates with disease activity and not with chronicity. So it's a good marker potentially of what's going on in the kidneys. But what's particularly interesting, and this correlates with a bunch of other studies that Dr. Fava also presented, that the urinary PR3 can also be checked. And Dr. Fava has done a lot of research on these urinary biomarkers, and PR3 is certainly one of them. And in the plenary, they showed evidence that PR3 marker, when you measure it both at 6 months and at 12 months, it predicts kidney function at 3 years. And so looking at it 6 months, 12 months down the road, it can predict which patients are going to have a decline in their renal function. And that's actually was expanded on more in Dr. Fava's session, which was 0850, where he looked at some of these urinary biomarkers, and particularly IL-16 is the one that showed up the most. And so when he looked at it, IL-16 was also predictive, but in particular, when you combine IL-16, PR3, some of these other urinary biomarkers, that kind of combination approach is much more predictive of renal loss than our traditional markers like proteinuria, which have not fared that well. And so I think there's a lot of promise here, both in understanding the role of PR3 in the kidneys and also maybe using some of these biomarkers for that liquid biopsy.
Yeah, it's extremely important. I know a lot of my patients would prefer to submit a urine sample than to submit their kidneys for the biopsy, for sure. What would be interesting is, like trying to predict using this biomarker in patients, who have low-grade proteinuria, because per guidelines, you shouldn't, or you don't have to biopsy until your proteinuria is like more than 300. And, we're missing a lot of cases of lupus nephritis, I think, if we're not being a little bit more vigilant. What kind of comments do you think about that, Sheila? Are you submitting your patients to a lot of biopsies, or what do you think?
Yeah, so actually, I was about to give a comment on that because, of course, here in this part of the world, biopsies are also costly. And again, patients wouldn't really consent to doing a renal biopsy left and right because, of course, they wouldn't want any poking of their of a needle being poked into their kidneys or whatnot. So if we were to if there were biomarkers that would be available, that would be less expensive, and it's non-invasive, then that would be better than subjecting to renal biopsies. And you're correct, because not all patients with low-grade proteinuria are, really responding well, or at least if we would have biomarkers, then it could also help in monitoring treatment response.
Right, right. So, and Eric, do you know, like, this PR3 marker, is this the same PR3 for like GPA? And have they studied this in other diseases with renal manifestations?
Yeah, I mean, certainly we see involvement with this in vasculitis absolutely affecting the kidneys. And certainly we see this more in that, in the proliferative lupus nephritis. So it's certainly a different phenotype here, but we know looking back that patients with lupus can have PR3 antibodies and AK antibodies. But so, I think it's a little bit, I don't have a great explanation there. I think it's definitely something that we need to learn more about exactly that role. But I think it's a fascinating association that, it's not just these serum levels, it's actually looking at the biopsies themselves.
Yeah, no, absolutely. Sheila, what have you learned during the conference?
Okay, so since Eric started with biomarkers, I'm also gonna ride on what he's he started with the discussion. But this one, I saw an interesting study. It's in the poster sessions. If I'm not mistaken, it was presented yesterday. So it's abstract 2297 about interferon alpha, so biomarker to predict flares in lupus nephritis. It's from the group of Dr. Garcia from Toronto. So we know that for just a brief background, interferon alpha gene expression predicts the higher interferon gene expression is seen in renal tubules of patients with SLE, and those with higher expressions would less likely respond to conventional treatment. So the group wanted to determine if the amount of interferon alpha in the serum at the time of a lupus flare would predict response to therapy, subsequent lupus nephritis flares, and decline in kidney function. So their outcomes were look into complete response, the number of flares during the time of follow-up, and any decline in GFR. And so their results show that serum baseline levels of interferon alpha did predict complete response at 2 years from the lupus nephritis flare. So meaning that patients with higher baseline levels of interferon had a greater risk of having 2 or more subsequent flares, especially 2 years after the follow-up. And that every increase in 1 unit of interferon alpha also increased the risk of having 2 or more flares by around 35%, and the risk of having a decline in kidney function during follow-up. So what would be good, or what would we get from results of this study? Well, again, it could be interferon alpha could be a good biomarker to predict renal flares in the future.
Yeah, I mean, biomarkers are definitely something that we are in need of, because, not everybody has a double-strand DNA. Not everybody, sed rate or CRP goes up during a flare, and not everybody has, the traditional markers that we normally check in order to predict flares. So I think we need definitely more specific biomarkers. And then going along with biomarkers, there was also like an abstract that I saw that was really interesting, that was looking at the NT-proBNP levels in lupus, because they were trying to predict, like which one actually had cardiovascular damage. And they found that at certain levels, like if the level is more than 133, it was strongly associated with underlying cardiovascular disease. So, like we were always taught, if you don't die from lupus early on, you die from cardiovascular disease. And when the patient presents to the ER with chest pain, I mean, everybody thinks it's myocarditis or pericarditis, but they have to think about MI. And so to have like these kind of biomarkers, I think that would be helpful. What do you think, Eric?
Yeah, I actually had that on my list of the top lupus posters as well. So I really liked that, they had set cutoffs, and the interferon alpha of 0.6 increased the risk of 2+ flares, and 1.3 increased the risk of decreasing the GFR. So I think it's helpful that they're able to do these analyses and really say, certainly, it increases with each unit of one, but there's clear cutoffs that should sound alarms that patients are at higher risk with these different features. And I think we've had these traditional markers of severe lupus disease and lupus nephritis for a while that we've thought of, but kind of looking at the epidemiology and double-strand DNA, but I think becoming more sophisticated and knowing which patients are at higher risk or need more aggressive treatment, is important.
Yeah, and then to distinguish also, because sometimes, like it or not, these patients have fibromyalgia and they say they hurt all over. And you're like, well, is this fibromyalgia or is this from lupus? So I really like the idea of more specific biomarkers that we could follow and actually have great sensitivity and specificity. So I'm going to talk a little bit about cardiovascular disease, because I think that, kind of like what I was saying with the NT-proBNP and cardiovascular risk, I think cardiovascular disease is something that's not screened for well with lupus, because we think these women, they're younger. We don't think about the classic older male chest pain going down his arm or whatever. But and I don't know if you saw this, but last year EULAR made recommendations for cardiovascular disease management in lupus and other connective tissue diseases, and they had like the 4 pillars, which was increased cardiovascular risk awareness. You got to screen for it, you got to manage risk factors, and then you have to educate the patient. So you got the 4 pillars. And I know, like, we have to do so much. We have to educate them about the disease. We have to educate them about their medications, talk about vaccination, reproductive health. And now on top of that, we're going to have to talk about cardiovascular disease. And we have always thought, well, is cardiovascular disease that prevalent? And so there were a couple of abstracts. There's abstract 1442 and 1469 that looked at the prevalence. The first one is in a Danish lupus cohort. So it's a 20-year registry. They had over 3,000 lupus patients, and that were matched to 60,000 healthy patients or controls. And they found that the prevalence of MI in lupus was about 3% versus 1.4%. So it didn't seem like that high. For cerebral vascular disease, it's 7% versus 2.7%, and peripheral vascular disease, 5% versus 1%. But even so, the fold increased risk in lupus patient, 5-fold increased risk in cerebral vascular disease and peripheral vascular disease, and a 3-fold increase in MI. Now, if you're a man with lupus, that increases a whole lot more, like 8-fold and 6-fold. And then there's the Lupus Manhattan surveillance program that's over 1,200 patients. So their cardiovascular risk is about 14%, and the risk does increase with age. It also increases with patients who are non-Hispanic Blacks and Hispanic patients. So we have to also understand the socioeconomic determinants that go into this. And so cardiovascular disease is also an area that's dear to my heart. No pun intended. I don't know, do you guys screen for cardiovascular disease in your patients?
Yeah, so I'll first answer the question. Well, yeah, it's really, it reminds me of what my mentor would always say, that it takes a village to take care of a lupus patient, because of what you just said about, we have to, we just don't look into what active organ involvement is happening within the patient, but you also make sure that, or you screen for other problems like cardiovascular disease, your vaccinations, and all that. Honestly, sometimes, because, especially if you have your lupus patient, which has been your patient for a long time, it's really hard sometimes when they would complain of, I think I have chest pains, but I also hurt all over. So, you have to really be able to differentiate what that patient is having, um and you realize that, every time a lupus patient comes in, or, well, any rheumatic disease patient in particular, but especially for lupus because of their increased risk of cardiovascular disease, then you would always have to screen or monitor. Usually what I would do is, I would, with monitoring, for example, for a lupus patient, at least every 3 months, you monitor your lipid profiles. You always check or always ask if there are symptoms of chest pain, or any shortness of breath, and a baseline to the echo would also help. And then you don't forget to ask about the family history. So it's sometimes a bit of a burden as well, but if you don't manage, or if you don't address these problems, lupus patients won't just die because of their nephritis, but maybe because of MI, or a stroke.
Right. And we tend to underestimate, cardiovascular risk. The guideline says that if you use the Framingham score, you have to multiply it by 2. I don't think a lot of people, one, calculate, cardiovascular risk scores, and 2, I don't think they adjust for it. And it's interesting that you had mentioned getting a baseline echo, because there were actually a couple of abstracts that look at echoes and assessing cardiovascular risk. And they found that the people with greater left ventricular mass, those patients actually had higher rates of cardiovascular disease. And that's something that we could consider adding into our screening. Now, obviously, the guidelines really don't clarify. They just said, oh, you should screen patients, but really don't give us an idea of how. What about you, Eric? How do you screen your patients, or do you?
Yeah, I think I think these things do fall on our shoulders. I think it's also important. I talk to every patient when I meet them that it's really important that they have a good primary care doctor, because rheumatologists do ultimately fall short. But I think when it comes to those pillars, I think we need to think about controlling all the controllables. That if they're a smoker, we need to address that for their lupus and for their cardiovascular disease. Their weight, their lipids, their blood pressure, their blood sugars, all these things, affect. They're related to the medications we give. They're related to the lupus, and they're related to their cardiovascular risk, separate and dependent and independent of their lupus. So it's important that we're thinking about these things, and I try to think about those things with them, but I also really want to make sure that they have a primary care doctor who's addressing it as well, and one that is working with me and understands that there's a higher risk. But it's a challenge to address all of that sometimes when they're coming in with swollen joints and these other issues. I thought, I always tell patients that the risk of cardiovascular disease is higher, which we certainly have lots of studies that you referenced that show that. There's another poster that I saw that also showed not only is the risk of a heart attack higher, they looked at 1 million STEMIs, and I forget which database this came from, but they compared the lupus patients to the non-lupus patients, and it showed that not only is the risk of having a heart attack higher if you have an ST elevation MI, your odds ratio of mortality is 1.3 compared to someone who does not have lupus. So, you're more likely to have cardiovascular events, and the outcomes when you have it are worse in our patients. So it's critical.
Absolutely. What are some other things that you found, Sheila?
Okay. So since we've been talking about cardiovascular disease, so I saw a few studies on SGLT2 inhibitors. So it's already a fact, or the guidelines exist, at least for patients with type 2 diabetes and those with established cardiovascular disease that inhibit the SGLT2 inhibitors reduce MACE, particularly non-fatal MI and non-fatal stroke or cardiovascular death among these patients. So, and clinical trials for SGLT2 inhibitors, unfortunately, have not included any lupus patients. So it's interesting. There were a few abstracts on SGLT2 inhibitors looking at its effect or what outcomes it produces or it affect or how it affects patients with lupus as well as those with lupus nephritis. For example, Professor Michelle Petrie in their abstract 1492, although the sample size was small, but they reported their early experience with SGLT2 inhibitors. So they found that so these were SLE patients who were also given SGLT2 inhibitors for their diabetes. And so they found that prior to starting SGLT2 inhibitors in their cohort, the average annual change in GFR was a decline of 3.1. And after starting the medicine, the decline went to 0.9, although there was an observable difference, but it was not really significant enough to see the effect. And there was also the average annual change in proteinuria as seen by the UPCR was an estimated increase of 0.4 prior to starting the SGL2 inhibitors, and after starting the drug, the average annual change was estimated to decline to 0.37. Again, the differences were not that statistically significant. So from their cohort, there seems to be a marginal benefit of SGLT2 inhibition, but of course, with a small sample size and probably more investigations and a longer follow-up, then more conclusive data would show if there were any really any advantage of giving additional SGLT2 inhibitors for lupus patients. And then similarly, abstracts 1579, that's by the group of Dr. April George, and 0590, they also looked into SGLT2 inhibition using a target trial, emulation, target trial emulation network. So what they found were as the use of SGLT2 inhibitors was associated with a lower risk of renal progression, as well as lower risk of MACE, compared with those patients on DPP4 inhibitor use.
Right. Do you know what percentage of your patients might be on those kind of medicines? Eric, what do you think about those results, and would you put your patients on it if they had diabetes or an indication for it?
Yeah, I think certainly if they have diabetes or an indication from there, I think that's clear. And there was a conversation we had when we did the daily topic panel on Room Now. Is it because of the lupus nephritis that we're treating, or is it because we're treating the diabetes? And obviously that's important for the kidneys as well. And I think it's important as we kind of extrapolate beyond, and we think is it useful for our non-diabetic patients? Should we be using them? But I think ultimately, regardless of the one, in the diabetic lupus patients, I think we see that they work, and I'm very struck by the evidence, especially when we compare them to some of the other hypoglycemic agents out there.
Right. And I think that there's going to be more ongoing studies as more patients are getting onto these drugs. It would be really interesting to see, once they get their glucose controlled. And you just think that with the DPP4, their glucose is better controlled, but yet it doesn't still have the same effects. So it's a non-glycemic issue. It works in a different mechanism of action. So Very interesting, though. Social determinants of health. Okay, so I saw this one abstract. It's really cool. It's by Megan Close, so from Duke University. And what she did was she just wanted to see, basically the patient's perspectives in a way, and why they might not be adherent to therapy. Because, we all have patients who they come in, you're like, you're taking your medicine, right? And they're like, sure. And then you realize, oh, they haven't even picked up the bottle from the pharmacy in 3 months or something. So what she did was, this is let me see what the abstract number is, 0190. Anyway, so she took a survey of 282 people, and the median age is about 47. They were 90% female, 57% Black patients. And so what she did was compared Black patients to white patients. And she found that the Black patients were more likely to be single, they're working full time, their annual household incomes under 50,000, and less likely to have private insurance. And so the most common reasons for non-adherence among Black people compared to white people was I forgot or I was busy. So that's about 69% of those folks. And then about a third of them says I was too tired. And then a third said, I'm tired of taking medicine every day. And what's also interesting is that there's a greater instances in Black patients where they're saying, because I'm feeling good, I don't need to take my medicine. So, and that's in comparison to white patients. And so I wonder, there's a lot of room for education here for everybody. And one other thing that she also noted was white patients were more likely to miss a dose of their medicine if they felt too depressed and no one could help them. So that's also one other thing. And so these were all adjusted for demographics, as well as other kind of variables. I just find it fascinating, particularly from a patient perspective, as to, how they do and what's going on in their lives. And I just wish more people would take the time and kind of figure out, what is going on in your life? Why is your disease so active? Are you taking your medicine? And just really ferret it out. What do you think, Sheila, about this abstract?
Okay, yes, it really, well, actually, it's similar with our situation here in our country, where you've mentioned patients would simply stop taking their medicines because they feel well, and then after a few months they'll go back to your clinic, and if you ask them, oh, it's because I forgot to take the medications, or I just stopped it because I'm feeling better. But when you look into the root of the problem, education really plays a big hand in our patients with lupus, and not just with the patient, but also with the caregivers, with the family. That's why, for at least for new patients, sometimes I would take a longer time to talk to them, because first of all, if you say, okay, you have a diagnosis of lupus, the next would be the flow of tears from the patient. So it's really hard. And then you also have to talk to the caregivers, to their families, because, well, at least from my experience, when patients receive news about them having lupus, it's like already getting a diagnose getting it's like getting diagnosed with cancer. It's how that it's that bad. So yes, unfortunately, there you also add to the fibromyalgia, to the depression, which can also be a different topic of discussion altogether. But yes, there's really a large burden of disease. And I think just adding to that, Kathryn, because I came across an abstract. I'll take a look at I'll give the number later, but it looked into the reproductive history and HPV vaccination status of patients with SLE and RA, and the findings show that there's still low rates of vaccination of HPV. And when asked, there was a questionnaire there, and when the patients were asked why they did not receive any shots of their HPV, the main reason was that they weren't really given the opportunity, or it wasn't really discussed with them by their doctor or by their rheumatologist. And we all know that, vaccinations with HPV, cervical cancer screening, it really helps a lot. And with our SLE patients at risk, it's really important that, again, we go back to all our lists of doing, okay, screen for vascular disease, do this, do that, on top of all this. And then you have to really educate your patient. I believe that if a patient is really educated about what they have, everything follows. They'll be compliant with their medications. They will be really aware and empowered about their disease, and it will come from them. I mean, it really helps. I mean, we rheumatologists, we're here, we give options, but ultimately it's still the patient. We need to help the patient because they will decide, or it's up to them. And they are patients. They're not just numbers, or they're not just anything that we treat, but they're human beings. So it really does require a holistic approach in treating lupus patients.
Well, yeah, Eric, go ahead.
Yeah, I think that was just an excellent way to sum that up. And I think we have all these new medicines that we're talking about, all these new therapies, and that the simplest thing we can do is make sure a patient is taking 1 or 2 pills of hydroxychloroquine a day, because we know that's the simplest, best intervention that we can do, along with all those other cardiovascular effects. And those are probably the best things that we can do, spending our time and addressing each of those barriers. I'm a big proponent of checking hydroxychloroquine blood levels. I think it's a really useful tool, and I tell patients, sometimes I do it in the guise of toxicity. I say I want to make sure you're getting the right amount, a safe amount, but I think it's a good launching point for conversations. And I tell patients that it seems a little bit lower this month. Tell me what's been going on. You want to make sure these are whole blood levels to get kind of good data. But when we get a good result, I think it can launch into a conversation. It gets into why they may not be taking it. It gives me a chance to give them congratulations when they're telling me that things are that they're taking it better, or if they're taking it better and their disease is still not under control. I have that data point. And so I think it's a huge issue, in particular lupus patients, that at least 40% of our patients are not taking the medicine the way we prescribe. And we can come up with all the advanced therapies in the world, but it doesn't address it if there are barriers that we're not addressing.
Absolutely. So before we wrap up, do y'all have any last words for our viewers? I'll start with you, Eric.
Yeah, I think I could just kind of piggyback off the other point that Sheila brought up about HPV and vaccination. That I was astounded by another poster that showed that HPV rates of abnormal cytology and high risk strains were about the same as HIV positive patients. And so I think, again, it comes back to a conversation of all the things that we want to be addressing. We can think about these newest molecules, but thinking about vaccination, screening, cardiovascular health, all these modifiable risk factors, all these things we can be doing for screening. That's really the thing we can do to help lupus patients the most.
Absolutely. What about you, Sheila? Any closing remarks?
Okay. So just getting from the background of, we know that SLE is a systemic disease. And so it's not like if they have active nephritis, we'll just target or we'll just treat the nephritis, but it's really a holistic approach in terms of SLE management. And I'm looking forward to hearing about more information or research on biomarkers and non-invasive things that we could do to help our patients monitor treatment or new therapeutics. But again, just like what Eric said, if you have all this, even if you have all the advanced treatment options or the tests available, but then you don't look at the patient, you don't treat your patient, nothing will really work. So I think, again, also, we rheumatologists, of course, we treat our lupus patients, but it's also a good thing if we ask help from other specialties, because again, it takes a village to treat a lupus patient. And yeah, I guess that's what I just wanted to say.
Yeah, like it or not, we are the primary care doctors for our lupus patients, because they could be stubbing their toe. Their primary care doctor is going to send them to us and say it's lupus.
Yes.
Well, thank you all for joining me. I just want to remind our audience that tonight we have the daily recap at 8 p.m. Central Time. There's also a psoriatic arthritis panel at 9:30 p.m. tonight, Central Time again. So I hope you all continue to follow our coverage. Thank you so much to both Sheila and Eric, and we will catch you all later. Bye.